Hi everyone, my name is Dr. Comfort Takang. I'm a second-year internal medicine resident at the Manatee Memorial Hospital in Florida. I present to you a complex diagnostic approach in a case of idiopathic bifocal acute transverse myelitis. Co-authors along with me are Dr. Uche, Dr. Chukura, Dr. Wise, and Dr. Marcialis, our program director. This is a case of a 63-year-old male who presented with painful paresthesia from his nipples and below, progressing to numbness of his bilateral lower extremities, urinary and bowel dysfunction, onset 10 days prior to presentation. His past history is significant for recurrent herpes labialis with last outbreak 3 weeks prior to presentation that was treated with a cyclovir. Clinical examination revealed saddle anesthesia with absent spinothalamic tract sensation from T4 and below, intact dorsal column sensation bilaterally, roughly intact cranial nerves and cerebellar function, no focal motor deficit, normal reflexes with negative Babinski. At this time, our possible differential diagnoses were broad, including demyelinating disorder, infection, autoimmune conditions, non-inflammatory conditions like neoplasm, vascular myelopathy, as well as idiopathic acute transverse myelitis. An urgent MRI of the spine revealed intramedullary T2 signal abnormalities with enhancement at T3, T4, as well as T7, T8 levels, indicating a myelopathy. Next was to determine if the myelopathy was inflammatory or non-inflammatory. This was done with the help of a lumbar puncture. CSF analysis revealed lymphocytic predominant pleocytosis. At this point, our working diagnosis was an inflammatory myelopathy, more likely transverse myelitis. This was based on the acute onset and rapid progression of symptoms, bilateral sensory dysfunction with a clearly defined sensory level, autonomic dysfunction with no evidence of compressive cord lesion, as well as CSF pleocytosis and gadolinium enhancement that was indicative of inflammation. At this point, our patient was started on high-dose pulse steroids. Next was to determine the cause of the transverse myelitis. Our goal was to distinguish between idiopathic versus secondary or disease-associated transverse myelitis. Brain MRI ruled out the presence of lesions suggestive of multiple sclerosis or other CNS inflammatory demyelinating disorders. CSF findings of no oligoclonal band also helped rule out multiple sclerosis. Meanwhile, autoantibody testing was negative. Through extensive antibody and serology screening, we ruled out systemic inflammatory disorders such as SLE and Sjogren's syndrome that can present with transverse myelitis as an initial event. Our patient was also negative for paraneoplastic antibodies associated with myelopathy. A CT of the chest, abdomen, and pelvis was negative for possible neoplastic lesions or any evidence of sarcoidosis. Extensive infectious workup, including but not limited to meningococcal encephalitis panel, HIV testing, syphilis serologies, and pan cultures were negative. Certain metabolic myelopathies that could mimic transverse myelitis like copper, vitamin B12, and vitamin E deficiency were ruled out. Finally, a spinal angiogram was needed to rule out vascular myelopathies. However, given a low clinical suspicion for it, in the setting of inflammatory CSF findings, and patient significant improvement of symptoms with 5 days of pulse steroids, the risk seems to outweigh the benefit and the patient declined the procedure. Acute transverse myelitis in our patient was considered idiopathic despite our patient's recent herpes labialis outbreak 3 weeks prior to presentation, based on negative thorough workup and no evidence of active infection. Thank you for your kind attention.